All right, let's recommence. We've got one major item for discussion in this section of the board meeting on restoration and recovery, which we've begun to explore at different points in the meeting so far. But Richard, do you want to just take us through the highlights of your report, and then we can have a discussion?
I shall. Thank you very much, Stephen. As you say, several elements of this has already been discussed or brought into play, so I'll try not to duplicate those elements. What I'm actually going to try and do is I'll take the paper as read, which is very much an internal focused paper, but I think, as colleagues have already alluded to, it has been a long and interesting week in terms of external development since we submitted this paper to the board. So I will try and pick up on some of the changes that have come down from the centre. Interestingly enough, they largely reinforce, as colleagues I think have already alluded to, they largely reinforce work that we had already begun. And so I wouldn't have suggested that any of what follows in the phase 3 letter, which, as Joe said, we will send out to you in its 13-page glory, any of this will be a huge surprise, and that it does pick up on areas that we've already set in place. So I think the opening slide tried to set the context for where we were coming, and it said we were coming to the end of phase 2, moving into phase 3. That was indeed prescient, because Friday last week we got the phase 3 letter. I think initially that was due to be sent out in June, but we received it on the 31st of July. And it does very helpfully set out some of the things that we had already been working on. And what it does is summarise 3 areas of national priorities through to the rest of the end of this financial year. As Damien has talked to, the most important area, I think, of that in terms of how much work it will absorb across the organisation is the need to return to a near normal level of activity before winter. So the letter talks about seizing the window of opportunity before activity ramps up, demand increases, and we all find ourselves back into the usual joy of winter planning. And that's what I'll pick up on as this report goes on in terms of the work that we're doing over the remainder of this month. We also need to develop a winter plan, as Imran was talking about, but one that includes the potential COVID impact on that. And then the final priority that it outlines is baking in improvements that we've made through COVID, but also ensuring that we continue to support staff and tackle inequalities. And again, in those 2 areas, Monica has already given a fairly comprehensive update. So in terms of what that area around returning to near normal means, in the appendix, members will have a submission that we made around our initial expectations of where we felt we would get to in terms of elective inpatient work, day case work, and outpatients. What the letter says is that in September, so not by the 1st of September, but in September, we will be at least 80% of pre-COVID activity for elective inpatients, day case work, and outpatients will be at 100%. And then in October, we will be doing at least 90% of elective inpatient activity compared to pre-COVID levels, 90% of day case work, and 100% of outpatient work. So what that's doing is essentially bringing forward fairly significantly work that we had already done around where we thought we'd get to by the end of this financial year. And so essentially, what happens next? Well, we are required to make a submission through the ICS by a draft submission will go to our ICS by the 1st of September, and then a final submission will go from the ICS on again up to the centre by the 22nd of September. So back to the point we were touching on earlier, the remaining 3 to 4 weeks are about going through, and Damien touched on the work that we're doing, going through with colleagues around assessing operationally what is the activity that we are expecting, what is the capacity we think we can bring on in both theatres, and in bed stock. What is the workforce that we will have likely to be available that requires that, and what the financial implications will be of opening up any potential additional capacity, i.e. waiting list initiatives in our priority areas, weekend working, longer hours, all of that. And that work is going on. And I think what I would like to do is bring forward ahead of the 1st of September, and we may need to share it outside of normal governance, but bring forward so that the board can see those plans that we are submitting, both at draft and then at the finalised plan in September. I suppose a number of other issues that have been touched upon that relate to restoration and recovery internally. Joe's talked about as we move from the restoration phase into recovery. So we've gone from rebuilding into making this stuff more like business as usual. We're also looking at the governance of restoration and recovery. So these will now be exec level drop-in meetings, so execs will be encouraged to attend. We have realigned our work streams so that they are consistent with the acute collaborative work streams, which in turn are consistent with the ICS work stream, so that we're all working on the same areas and giving them the same governance and architecture, if you like. And as Damien's already alluded to, there is a recognition that after the 1st of October, our finances return to something more like a cost and volume or a normal sort of arrangement. We move out of the block as we have currently enjoyed it. So I think in summary, those are the areas that I would like to flag as the main points following the letter, and I'm happy to pause and take questions from colleagues.
Thanks, Richard. Let's start with Jackie.
Could I just ask you about the paediatrics? Just the update there given it's red, and it seems to be a space issue as well as restarting activity. Can you just give us some assurance on what we're doing?
Yeah, I'm happy to ask Imran and Joe to follow up with the details. The red that you refer to there, this is a copy of the reports that go through to the exec team. Specifically, we'd got some issues around restarting all of our acute and community paediatrics that were related to not enough space being identified. My understanding is that most of those issues are now fixed. As Adrian updated on looked after children, we'd never paused any of that work, and I think so that this is now an amber in the latest update. This was at the time of submission. I think Chris had not met with Brenda and Melanie, the divisional leadership team, to finalise those issues, but I'm happy for colleagues to step in if I've misspoke.
Adrian.
Thanks, Steve. So the Friston ward, our paediatric ward at Eastbourne, was taken over for expanded critical care capacity, and our SPOW activity necessarily was therefore curtailed somewhat and moved down to what was the Scott unit, and then there were plans to extend the Scott unit. Friston remains given over to extended critical care capacity. So at the moment, we're still constrained in terms of the space for outpatient SPOW and the ongoing activity that's related to that. So it's an Eastbourne space issue rather than Conquest. We've also yet to restart the Pediatric Surgery at Eastbourne, similarly because of accommodation for children. So the red is that at the moment we're not returning to normal paediatric activity because of those space issues. But as Richard said, solutions are being worked on, and there are plans, for example, to extend the Scott unit that the estates team are considering.
Whilst that is happening, have we got any issues on growing waiting lists or referrals, and is there sort of clinical review if that is happening?
I see Joe's got her hand up as well, and Joe will be closer to some of that die, but not that are red flagging any more than we've talked about in the generality, Jackie. Joe?
So just to answer that bit directly and then just come back to the plans. So as with all of our waiting lists, they're all being reviewed clinically, and urgent patients are being brought in. The old EME at Eastbourne and the Scott unit are being looked to be redeveloped, and plans are in place to develop that as a paediatric assessment unit. The division with Chris have identified an off-site suitable area, still just to be finalised at the moment, that would allow community paediatrics to restart. And that by having it off-site, obviously from an infection control perspective, gives that more sustainability going forwards, and actually is probably the better model going forwards. In terms of paediatric surgery, Adrian's right, we haven't restarted it at Eastbourne, but we have restarted paediatric surgery because it needs to take place in a dedicated area. So that's happening at Conquest at the moment. We haven't got an identified space that meets those requirements at Eastbourne, but there is an intention to return that back to Eastbourne as soon as possible.
Thanks, Jo. Karen.
So one point just relating to the last discussion, and that is, does that mean that paediatrics, urgent paediatrics or priority paediatrics from Eastbourne for surgery are going across to Conquest? And then on a separate thing, just a clarification really, on the first week work stream non-elective care, it says identification of additional trackers will be needed to support the additional workload. What kind of trackers are you talking about? Not clear what the milestone or action is there. Thanks.
Thanks, Karen. I think Jo nodded in response to your first point. The trackers, these are around our medically ready for discharge patients. So this was around the discharge hubs. There has been an issue around how we have needed to staff them, and this goes back to staff being redeployed from their original roles to support the discharge hubs. Initially, there was more of a local presence and alongside a regional presence, and we've always sought to staff those effectively. But of course, as staff have needed to go back to where they originally came from, medically ready for discharge and discharge hubs have been an increased pressure point for us. So we've needed to, so at the time we wrote this, there was a challenge around identifying those staff. And again, I believe we have done that, albeit through a kind of temporary secondment arrangement, so that we keep the flow through the back end of the hospital open.
Thanks, Karen. Any other questions for Richard? Richard, thank you. Obviously an important piece of work, keep us up to speed with. Good. Well, that takes us to a number of papers for noting. First of all, briefing papers from the South East Regional Chairs meeting, which was 2 months ago. It feels a little bit like, slightly like ancient history reading this now. It's probably a fraction more detail than people really needed, and things have moved on quite a long way. We've got audit committee minutes attached, finance and investment annual report, and pod committee. I wasn't intending to do anything other than draw those to people's attention for information. In terms of questions from members of the public, on this occasion we've just had one issue raised with us, which is asking the question about why we're not live streaming, and we're working on the technology to allow us to do that. We experimented with the AGM, which worked well in some respects, and we learned some lessons from that, and I think the current intention now we're aiming for the October meeting as the date on which we would start doing live streaming, if that's the correct terminology for what we end up doing. And indeed, that is our next meeting on Tuesday, the 6th of October. So if there are no other urgent items, I'm going to draw us to a close. Thanks very much, everybody.
Thanks, Steve.